Hey, thank you for coming out today, and I hope that this will be, in one sense, a life-saving morning for you to hear from some experts in the field that address that higher risk of post-transplant cancer that I just was talking about before the meeting started. And again, in summary before we start, so it's on the recording, the key is, one, to understand that higher risk, which comes mainly from the immune suppressant meds you have, but many other things too. Secondly, to watch out for the symptoms and do the preventative testing that they're telling you about. And third, don't ignore those symptoms. Go get them addressed. All cancers that we found, well, most, can be cured if addressed early enough. And if they're not addressed early enough, they can be fatal, even skin cancer. And so as I was introducing just before, why this topic today actually goes back to a meeting I had with Melinda, where we had her come speak about post-transplant cancer, which is a subject that I'll give you more information about later. But as I said before, most patients forget or don't know about the higher risk, so they don't pay attention to it. Second, studies have shown it's the second most common cause of death post-transplant. Recognized and treated early, most cancers are curable. And so that's why we're here today, to give you that education so you can identify them, get them treated and cured. And so our panelists today, you've read this on the flyer, but what I want to do is just refresh what they're going to speak about. So Dr. Ford McLean will speak about the different types of cancer which post-transplant patients are at risk and how we screen for those cancers. And that's the research area that she works in. Chris Miller, I talked about just before, a legend in the field, and I say that because I've heard that even outside here. Dr. Miller states that when diagnosed and treated early skin cancer is curable, regular examination of the entire surface of the skin is a key aspect of skin cancer surveillance. When I came to him for that first appointment, I was surprised when he said, take off all your clothes. I mean, that early dermatologist, where do you want me to look?
I'm lonely, Jim. Another indication of how lonely I am.
He will teach us how to spot precancers and skin cancers on the bodies in order to partner with the dermatologist so that the new, changing, and suspicious growth can be evaluated promptly. And then finally, how do you pronounce her first name?
Thuzar.
Right, Dr. Shin is going to tell us solid organ transplant recipients are at increased risk for developing skin cancer, as high as 65 times that of the general population. She'll be discussing why transplant patients are more likely to develop skin cancer, what variables contribute to the increased risk, and what you can do to reduce your risk. And with that, I'll invite our panel to come up to the front table.
Thanks for inviting us to tell you a little bit about skin cancer after, for staying safe in the sun before and after heart transplantation. We just had a wonderful presentation on all types of skin cancer, or all types of cancers after transplantation, and I'd love to share a little bit about how to keep your skin safe in the sun, and this can be done both before and after transplant. So I know you just heard that you do have an increased risk for all types of cancers. We're here to tell you that you do have an increased risk of skin cancers, and this increases after heart transplant. So we'd love to tell you about what risk factors those are. And second, we'd love to tell you how you can decrease your risk for skin cancer. So we'll talk about some sun protection towards the end of the talk. All right, so the first step is to really know your risk for skin cancer. And this is really because the higher your risk, the more diligent you must be in terms of protecting your skin and also going for your screening visits and looking at your skin at home in conjunction with your dermatologist. So that in the general U.S. population, this is all comers, your lifetime risk for skin cancer is 1 in 5. So 20% of Americans will develop at least one skin cancer in their lifetime. However, in the transplant population, this is greatly increased. So the risk of skin cancers in transplant population is about 50%, and almost half of our transplant patients will develop multiple skin cancers. And in many cohorts that have been studied, including heart transplant patients, skin cancer is the most common cancer after transplantation. So in terms of the incidence, so Penn participated in this nationwide study called Skin Cancer in Organ Transplant Recipients to establish a population-based incidence in the United States. So we worked with 26 different transplant centers across the country, looking at over 10,000 patients. And Penn participated in the study and contributed almost 10% of the cases. 10% of the patients that were studied in this research project were heart transplant patients. We looked at 2 years, 2003 and 2008, and really tried to figure out how common this is developing in our transplant patients. And in this cohort, the specific cohort, almost 10% of organ transplant recipients developed at least one post-transplant skin cancer during the follow-up period, which ranged from 1 to 10 years. And when we looked at the incidence rate, so this is incidence rates over time, so the skin cancer incident rate in organ transplant recipients is nearly 5 times the rate of all cancers combined in the overall U.S. population. So this puts it into something called a hazard ratio, but this is a very extremely high rate compared to the overall U.S. population. So in terms of what types of skin cancers you're at risk for, so squamous cell cancer is most common. So there's a 65-fold increase in squamous cell cancer incidence in patients who have had a transplant versus those who haven't. For basal cell, it is slightly higher than the general population, 10-fold. And for melanoma, so melanoma we care about because this is the least common skin cancer, but has the highest chance of posing a threat to your health. There's about a 2 to 3-fold increased incidence in transplant patients. So just to make sure everybody's awake and to get your participation, we're going to do a pop quiz. So 1, 2, 3, or 4. Which skin type is at greatest risk for skin cancer? 4. Okay, wonderful. So we know that patients with clear skin have a higher risk for skin cancer. And in that study that I described, when we looked at white race versus non-white race for squamous cell cancer, that was an 8-fold increase, and for melanoma, a 9-fold increase among transplant patients. So that really, the skin type really does matter quite a bit. All right, next question. Which of these people is most likely to have skin cancer? Baby in 1 or the older woman in 4? 1, 2, 3, or 4? 4. Okay, so we know that older age also increases your risk for skin cancer. And this is really across the population. This is not something, this is a risk factor for skin cancer in general. All right, so last but not least, who's more likely to get skin cancer? Someone who hasn't been in the sun much, or someone who's a farmer who's had a lot of sun exposure? All right, so we do know that environment plays a great deal in terms of developing these skin cancers. So that's why we ask about how much sun you've had, where you get all your sun, have you ever had a blistering sunburn? So these are important questions that we'll ask you during your visit. So many publications have really validated these common risk factors that we just went over. So this holds true before your transplant and also after your transplant. However, after your transplant, you do have some additional unique risk factors that contribute to skin cancer formation. So we know that male gender, so if you're a male versus female, you have almost 2-fold increased risk for skin cancer compared to your counterparts. So again, gender plays a role in skin cancer as well. We know that the type of transplant you've had also affects your risk. So this is something called an incidence ratio. It's how the rates of skin cancer, or how common it is by the type of transplant. So this is compared to patients who have not had a transplant. Heart transplant patients are almost 19 times more likely to get skin cancer than the general population, versus liver, which has the lowest rates of skin cancer, about 7 times increased risk compared to the general non-transplanted population. However, we know that among all transplant patients, so this is all patients that have been transplanted, we know that patients with a heart or a lung transplant will develop skin cancers at almost 1.5 times the rate of all abdominal organ transplant patients. So those are patients who've had a kidney transplant, pancreas, liver. So heart and lung patients, really, we want to keep a very close eye on, because even among all transplant patients, they're at increased risk. We also know that age matters. So if you're 50 or older at the time of transplant, you have a 3 times increased risk compared to your counterparts that were transplanted under the age of 50. So we know that age matters as well after transplant. And we also know that if you're older at the time of transplant, the time that passes until you get your first skin cancer is shorter. So the time to your first skin cancer is shorter, as well as the time to onset of subsequent skin cancers. And we also know that If you're younger when you're transplanted, you tend to develop skin cancers at a younger age than you would if you were not transplanted, so compared to the general population. So this is a young woman that developed numerous skin cancers in her 20s. So this is why we talk about pre and post-transplant. So the biggest risk factor for skin cancer after your transplant is if you've had a skin cancer before your transplant. So this is why we work in conjunction with your pre-transplant team as well to make sure that we screen your skin from head to toe to make sure that there's nothing concerning that will either hold up your transplant. We talked about the wait time after you've had a cancer, including a melanoma. So this is important for pre-transplant screening. And it's also important for us to know post-transplant because we tend to follow these patients a lot more closely. And then in terms of medications, we know that medications matter, and all immunosuppressants that we take can indirectly increase skin cancer formation. We know that minimizing immunosuppression can help decrease your skin cancer risk, and we definitely want you to discuss your immunosuppression medication with your transplant doctors. And we work very well with the transplant teams, where we all are kind of on the same page in terms of trying to minimize immunosuppression if somebody's developing numerous skin cancers or develops an unusually aggressive one. All right, so moving on to step 2. So how are we going to protect our skin from the sun? So we'll go over a few facts about sun protection and the environment where we're going to get our sun exposure. All right, so more audience participation. What's the most effective way to protect your skin from the sun? Avoid sun exposure, sun protective clothing, or sunscreen? Actually one. So avoiding sun exposure is really the most effective way. And so we'll talk about sun protective clothing and sunscreen, which are also very important, but the main thing is really to kind of minimize your sun exposure if possible. So in terms of our environmental factors, there's UVA and UVB. So UVB is most intense between 10 a.m. and 2 p.m. So if you've seen us in the clinic, we always tell you to try to avoid being out in direct sunlight between 10 and 2, because this is because the UV rays are at its most intense time between these hours. UVA, which also contributes to skin cancer formation, is relatively constant throughout the day. Is relatively constant throughout the day, which is also why we still tell you to practice sun protective measures even outside of this window. So in terms of, this is kind of showing how the sun's rays hit the earth. And so right between 10 a.m. and 2 p.m. it's hitting perpendicular to the sun. So all of the rays are hitting the earth and none are getting deflected. And even on cloudy days, we tell you to practice sun protective behaviors, and that's because the clouds block some UV radiation, but not all. And they also take away the natural heating that you get on your skin to tell you that you're getting a lot of sun. So sometimes a lot of people we know have gotten sunburns even on cloudy days because their skin is not hot or warm, but they are definitely getting UV radiation, and sometimes even enough to burn them. And so the levels of UV light really depend on many different things. We talked about the time of day, also the time of year, what latitude you live in. A lot of times we don't remember about the reflection of the sun's rays over water, also sand and snow. So even in the wintertime when you're skiing, you can get a significant amount of sun, especially on your face. And especially important to wear sunglasses too, because you can damage your retinas. Also it's also affected by what altitude you live at, and also obviously the weather. We talked about the clouds that block some but not all UV rays. Okay, and this is a picture to illustrate that even in the shade, you can still be getting a good amount of UV rays from reflecting from the sand and also the water. And so even we do love if you would sit under this umbrella, but we would still want you to put on sunblock and sun protective clothing. So what can we do? So aside from avoiding sun exposure, what can we do? So one is sunscreen, and then there's this cute little mnemonic or this little phrase to help you remember what to do. So it's slip, slop, slap, and wrap. So you're going to slip on a shirt, so that's your sun protective clothing. Slop on some sunscreen on all exposed areas, and we'll talk about how to apply that sunscreen. Slap on a hat. So we love hats. Hats physically keep the sun off of your skin, especially the ones with a wide brim that cover your ears. And Dr. Miller routinely says if your if no one's laughing at your hat, it's not big enough. And that's what it is, very wide for. And then last but not least, definitely wrap on sunglasses because the skin around the eye is very delicate and also prone to developing skin cancers as well. All right, so we'll talk about sun protective clothing. So when you read the label on any sun protective clothing, you should really be looking at the UPF, or the ultraviolet protection factor. These are a few photos to show you how clothing is actually more effective than sunscreen. So you can see this is a gentleman with a sweatshirt on. His face looks pretty red. What's really striking is the difference between the sun-exposed skin above the sweatshirt and the sun-protected skin on the chest. So you can see your clothing is pretty effective at keeping the sun off of your skin. This is another illustration. This is a hat. Without a brim, we would love to have your ears covered. As you can see, you can develop skin cancers in these very prominently located areas where you get a lot of sun. So below where the hat sits, you've got a lot of sun damage here and even some precancerous spots. Under the hat, he wears his hat every day. The skin looks pretty good. So you can really see kind of the difference that a hat can make as well. And this is just a picture of that skin cancer there. So in terms of UPF ratings, this is what you want to look for. Most of the ones that I've seen in the stores are usually 50 or above. There's many different brands that make these shirts. So they make all different kinds of shirts. They also call them rash guards that are sleeveless, with sleeves, long sleeves. Obviously long sleeves are better than short sleeves, and short sleeves are better than tank tops. They also make for golfers these just these sleeves, this UV sleeves, so that you can wear them with any shirt, any polo shirt or a short sleeve shirt, just to physically cover your arms. And the best part of that about this clothing is that it's reusable. It works as soon as you put it on. You can, it really kind of pays for itself over time, and it's not greasy. So if you don't like putting all that sunblock on, it's much easier to just slip this shirt off and on. Okay. And this was actually an article that was published showing that, especially for young people too, this is important, that clothing really is better than sunscreen, especially because it doesn't change over time, so you don't have to reapply the shirt. It's on, it stays on. So this is Colleen Bronstein is a supporter of our melanoma program here at the Abramson Cancer Center, and she actually has this website. This is just one option for sun protective clothing. It's called Sun Threads. I'm going to check out our website. Okay. So we'll move on onto actual facts about sunscreen. So every time I go to the drugstore, I'm pretty overwhelmed when I go to the sunscreen aisle because there's a bazillion different options. There's generic, there's branded, there's many, even within one brand, there's dozens of different options. So how do you really pick one out of all these things? And how can you pick one without spending an hour reading all the labels and going cross-eyed? So we know that we advocate for sunscreen because we do know that regular sunscreen use can help prevent both actinic keratoses, which are precancers that Dr. Lone will go over, and also squamous cell cancers in organ transplant recipients. So sunscreen really does work. So there's been a change in our sunscreen labeling, trying to make things a little bit more straightforward and easy to read, and really to set a standard for sunscreen. So now every single sunscreen that's on the shelf has to protect against UVA and UVB rays. So every single bottle on the shelf is a broad spectrum sunscreen. So that's important because we talked about UVB and also UVA rays. Both contribute to skin cancer formation. And then there's no such thing as a waterproof sunblock. So there's only a water-resistant sunblock, and there's only two types. One that's good for 40 minutes and one that is good for 80 minutes. So this is the time that you can be in the water before you have to reapply. So trying to make things easier for us. In terms of if you want to look for the best rated sunscreens, there is a consumer report about some of the best performing sunscreens that they tested. However, in terms of actual real life application, we know that people only apply maybe a quarter to a half as much sunscreen as is used for testing in terms of SPF or sun protection factor. So we all tend to under apply sunscreen. We don't use as much as we need to. And this has been shown by multiple studies that we don't use enough sunscreen. And what we really want to do is we want to make sure that we avoid selective sun protection. There's no such thing as safe tanning. So this is what we tell our patients in terms of how to apply sunscreen. So liberally applying sunscreen 15 to 30 minutes before activities. In terms of amount, it's the size of one shot glass. It's 1 ounce for a whole body head to toe application. And you want to use a sunscreen with the highest SPF that you like using. Sometimes if you get into the 100 SPFs, it does not give you 100% protection, and it tends to be a little bit greasy. So the minimum we usually advocate for is SPF 30. If you can tolerate a higher SPF like a 55 or sometimes a 70, that can sometimes account for the under application that we all are accustomed to applying. And then in the Consumer Reports report, the chemical sunscreens tended to more likely match their SPF. So these are things that do not have, so zinc and titanium dioxide are physical sunscreens. They physically reflect light, but the chemical sunscreens tended to perform better. I'll usually have you use something that has both in it, and these are just some lotions in a particular order that were very well rated by Consumer Reports. As you can see, they range in all different, they've got a whole price range. And these you can find pretty easily at the store. So Equate is like a generic brand that you can find, I think, at Target. But these are pretty easy to find and relatively inexpensive. Okay, and then in terms of spray sunscreens, we always caution patients about spray sunscreen. I mean, how many of you have been at the beach and someone's spraying themselves, but the wind is blowing more than half of it away? So spray sunscreens are fine if you use them appropriately. So we usually have you rub in the sunscreen with your hand after you spray a liberal amount, just to make sure that you've got adequate coverage. But if you're interested in a spray sunscreen, these are a few that performed well in the Consumer Reports analysis. Okay, so we talked about skin cancer, but we also know that sunscreen can be anti-aging, so it can prevent things like photo damage, these fine wrinklings, and kind of abnormal or kind of what we call dyspigmentation, pink spots and brown spots in the background. So this is a photo of a truck driver. So drivers get most of their sun on the left side of the window because we drive on the right side of the road. So you can really see a striking difference between the side that's been exposed to years and years of sunlight, even through the car window, and this is on the right side. This is relatively sun protected compared to the left side because it's not facing the sun. All right, and this is an example. This is a computer-generated image, what his face would look like if he had no sun exposure or minimized the sun exposure. And this is what he would look like if both sides of his face had the same amount of sun exposure. So I think this is a pretty striking message in terms of the aging part. So we're not talking about skin cancer even here, but just these sort of wrinkles and the darker color here. Okay. And then another reason why we advocate for sunscreen is that we know that regular sunscreen use can decrease the risk for squamous cell cancer and also melanoma, which Dr. Miller will talk about, but that's one of the deadliest forms of skin cancer. And we know that this is timed to your first melanoma, so people who applied sunscreen versus who didn't apply sunscreen, so people who did not apply sunscreen developed a melanoma at a much earlier time. All right, so in this study there was a 50% decrease in the occurrence of your first melanoma with sunscreen use. And then in the last few minutes, we'll talk a little bit about some newer things. So we'll talk about vitamin D and sun protection. We get a lot of questions about this. So we'll turn it back to you. So fact or myth? Rigorous sun protection can cause vitamin D insufficiency. Fact or myth? Okay, so we're kind of split. So this is actually true. So this is if you practice very, very strict sun protection. So this is Caucasian individuals who who either seek shade or wear long clothing, they may have lower levels of vitamin D and be at risk for vitamin D deficiency. But that's usually not standard practice. That's usually not how most people behave. So we do know that you can have lower levels if you're avoiding the sun because the sunlight is one source of vitamin D. But chronic sunscreen use, in this study, you can significantly decrease the production of vitamin D under very, very strictly controlled conditions, but under usual use conditions, that doesn't seem to be the case. And the reason why, I think we talk about vitamin D a lot these days is because there's been some studies that have associated low vitamin D levels with increased risk for other things, including cancers. So we are aware of how important vitamin D is, but in terms of where you get that vitamin D, the sun is just one place that you can get vitamin D. So if you're concerned about it, you can have your levels checked, but there are other ways that you can supplement your vitamin D intake. So there's lots of foods that are rich in vitamin D. There's milk, dairy, eggs, sardines. You can also take supplements. A lot of our patients take supplements. Sometimes if you're very low, you've got to replenish your levels, and then you'll be on a maintenance dose. So the sun really is just one of many different ways that you can get vitamin D. All right, so we'll go spend a couple minutes on some new stuff. All right, last couple questions. So fact or myth? So nicotinamide, which is a B3 vitamin, may prevent non-melanoma skin cancer. Fact or myth? Has anybody read about this? Raise your hand if you have. All right, so this is very new. So this is a fact. So this was an article that was published in a very important journal called the New England Journal of Medicine, and this was a trial that uses a derivative of vitamin B3 called nicotinamide. And so they looked at this in healthy patients and saw a 23% reduction in both basal cell cancer and squamous cell cancer. And that sounds very promising. When we looked at the actual data, it wasn't as convincing. But there are a few things that are missing from this, and this was a phase 3 trial, but it's still very new, so there's not really any long-term safety data, and especially with patients who take multiple medications, safety of in terms of drug interactions and any long-term effects from taking this vitamin chronically, we don't know about. There's really no data for melanoma prevention as well, which we also care about because this can pose a threat to your health. And then we take this with a grain of salt. We're very cautious about this because there's been many vitamins in the past that have kind of been promoted for anti-cancer or some health promoting properties like vitamin A, vitamin E, and in the long run, sometimes we've had some surprising results that are either conflicting or maybe even contradictory to what was first found. So although we're cautiously optimistic, we're still waiting for more data. I think the most important thing that we can that we derive from this paper is that although it's promising, there are very important populations that were excluded from the trial that may benefit most from this. And the first one is immunosuppressed patients, so that includes heart transplant patients, all organ transplant recipients. And so we're not really sure if this even applies to our immunosuppressed patients. There was a separate study, a very, very small study that was done in kidney transplant patients looking at this vitamin in terms of chemo prevention for skin cancers. There were only 22 patients in the study, randomized 11 to each arm, and they did show a reduction in the number of actinic keratoses and also basal cell and squamous cell cancers in the treated groups of the people who took the vitamin. But this did not reach statistical significance, which is which is what we look for, but it's possible that they just didn't have enough patients. They only followed these patients for 6 months, so we're not sure if this was a lasting, durable effect or not. But one take-home point is that there were no differences between the patients who took the vitamin and who didn't in terms of adverse events of things that complications that they had from taking the vitamin, and including creatinine, which is a marker of kidney function, or blood pressure, which we also monitor in everybody. So this is, I would say this is promising, but really I think we need a lot more research. So definitely if patients want to try it, we're usually not opposed to it, but we really definitely want to discuss this with their transplant team to make sure that it's safe from a medication perspective, and that we can monitor things over time. I guess I'll take any questions you might have.
I've gotten flagged on that for the statins, that there's some sort of interaction with nicotinamide statins that they didn't, I mean, my dermatologist recommended, I brought it here, and they said, we're concerned about that interaction.
Yeah, so I haven't heard that one, but a lot of times when we check for drug interactions too, a great resource for us is the pharmacy. And sometimes the interaction that comes up is significant, sometimes it's not. So I think when you look at the specific drug interaction, sometimes it is helpful to discuss with the pharmacist as well to see exactly what the interaction is and if it can affect even other medications that you're taking as well.
Okay, we hold other questions till after Dr. Miller. Thank you, Dr. Shin.
Hey, you guys have so many new. Dr. Shin, she didn't have a chance to be introduced properly because she wasn't here when Jim was introducing all the rest of us, but she's really taken the helm for the care of our immunosuppressed patients and their skin cancers. So a really important player at Penn to help people like you. And then the other thing is you guys are so fortunate with all the resources that you have. One of those examples is that you guys have pharmacologists dedicated just to transplant patients here that can answer questions like the nicotinamide. And are you a little bit scared after hearing some of those talks? So, what's the most common skin cancer you're going to get, right? Or what's the most common cancer of any type you're going to get? Skin, right? The other ones, they can happen, but they're at a much lower frequency, right? So the one that you're most likely to encounter, do you remember that curve? It's really close to what it is if somebody didn't have skin cancer, and the key is to find it early. So the good news is that we can catch most of these and help you out. And I would emphasize what Dr. McLean said, that you guys are the ones that make the difference. It doesn't work if it's just your doctor helping you out. You guys get to be your advocates. So at our Penn Dermatology Oncology Center, one of our clinics, the high-risk skin cancer clinic for organ transplant and immunosuppressed patients, is where we focus exclusively on the primary skin care of patients like you. And what we emphasize is this thing, it's like what the coach says before the game. Just focus on what you can control. Don't worry about the things you can't control. Focus on what you can control. You can control two things with your skin. Early detection. You guys got to be monitoring your skin and bringing attention to lesions that you're concerned about. And prevention. Try not to get them. Stay out of the sun, and when you're out, make sure you're protecting yourself. So you know what your risks are. But Thuzar went through those. Which is the one at greatest risk? 4. Great. Which one is the greatest risk? 4. Good. And which one's the greatest risk? 4. Good. All right. So if you're light-skinned, you're getting older, and you've had a lot of sun exposure, you got to be watching really carefully, right? So, now you got to know what to look for. And this can be dizzying for you initially. We all have lesions on our skin, and how many of you noticed that after you started your transplant medication, you started to pop up these warty lesions, or your skin got more oily all of a sudden, and you were wondering, why do I have these bumps, and why do I have those bumps? So it can be difficult, especially early on when you start your immunosuppressants, to differentiate between the benign and malignant. So these are the 3 most common skin cancers that you can get. Which one are you most susceptible for now that you're taking your immunosuppressant medicines? Squamous cell cancer. All right? So up to 65-fold increased risk. We're going to simplify this. You want to look for a few things. Pink spots, shiny, rough, and dark. Pink, shiny, rough, and dark. And I'm going to give you some examples. If it's pink and rough, more likely to be a squamous cell cancer or a precancer. If it's pink and shiny, more likely to be a basal cell cancer. And if it's dark, no. Okay, you don't even need me to finish, but I'm going to give you some examples anyway. So squamous cell cancers, they're often pink, They're almost always rough, it's very nearly always rough, and they often bleed. Now, squamous cell cancers have a precursor lesion. Some things they're not full-blown cancers, but if left alone, they could become one. How many of you I see some people at risk here have sandpaper-like texture on some of their skin. Those are these precancers. They're called actinic keratoses. You can often feel them before you see them. They feel like sandpaper. Sometimes they get a little inflamed. They're often pink and a rough white scale. That scale is adherent. If you take your fingernail, you won't feel like you can pluck it off. If you feel like you could pluck it off with your fingernail, then it's more likely to be a benign spot. So you see a rough pink spot that you can't flick the scale off of it, that's one you want to pay a special attention to. Pink, rough. Pink and rough equals squamous cell cancer. Pink and shiny, more likely to be basal cell cancer. Dark? No. Okay. Just keep hammering those. Which areas are most likely to be affected? Sun-exposed areas. So face, dorsal, backs of your arms, your lower legs. How many of you have scalps like this? You see a couple bald people in the area? Some rough spots on the top of your scalp. Backs of your hands. Any of you golf and have some rough spots on the backs of your hands? And if they're left, and we don't catch them early, they tend to progress. So you can develop arms that are rough in multiple places and multiple lesions. So we care about these precancers because 90% of squamous cell cancers have an associated precancer. But the good news is that most of those precancers don't. You can catch them before they progress to a squamous cell cancer. So here's what a squamous cell cancer looks like. What color is it? Pink. How does it feel when you touch it? Rough. Pink and rough. Here's another one. What color? Little pink. Rough to touch. Another one. Pink, some roughness, but it can bleed. That's one, if you have a bleeding spot, you want to get that one treated even more quickly. Sometimes they don't have a lot of scale on them, and these ones especially, if you have a bleeding spot that's not, if you have a spot that's bleeding without any reason to bleed, no trauma to it, you want to get that checked out. If you don't treat these early, you can get multiple lesions, and we feel bad. So this is an example of a great patient of ours that unfortunately passed away about 3 years ago. We had the good fortune of working with him for about 7 years. He was 17 years out from his heart transplant. He was a landscaper. That was his occupation. So the poor guy had so many lesions. And they can evolve into more serious ones if you don't treat them early. So we want to catch them for sure before that. Now, you can have benign warty growth. So this is everything that's rough and pink is not a squamous cell cancer. This is much more common. Many of you will have these rough growths. And some of you raised your hands when I asked if you had some new lesions pop up that are warty after your cancer. Basal cell cancers. So squamous cell cancers, one last time. What color are they usually?
Pink.
And how do they feel? Rough. All right, pink and rough. Think precancer, actinic keratosis, or squamous cell cancer. Basal cell cancer. What are the features?
Pink, shiny.
Pink and shiny. All right, good. What color is it? Pink. It looks shiny and it bleeds easily. Another one, pink, shiny. The pink color comes from they're often little blood vessels that grow into the tumor. Another one, this is pink. It's more flat, but what's the texture look like? Shiny. And sometimes you can get, here's a more subtle one. You might be less likely you can feel this better than you can see it. It's not so pink, that little scab is from a biopsy, but it's shiny. If you stretch the skin, it brings that out even more. And sometimes you can get some basal cell cancers that have some darker color, but what's the texture? Shiny. So shiny is nearly uniform. There are the pink spots. Let me show you another one. Where's the basal cell cancer? What color are you looking for? You're doing your skin exam. You're at home, just got out of the shower. Well, what did he say? I can't remember anything he said. He says, look for pink spots. All right, so we got some pink spots. There's a pink one, bleeds easily. But look at this. There's another pink one. More subtle, but it's there, right? Now you're tuned into the pink color. So those are both basal cell cancers. Most people would find the obvious one. You guys are going to find the less obvious ones now. Where is it? Where's the basal cell cancer? What color are you looking for? Your skin? Pink? Anybody see it?
They're right.
All right, fantastic. There you go. So now you know what you're looking for. Oh, we got maybe. Are you looking at this one right here? Okay. I don't know. Your eye's better than mine already. We'll hire you. Yeah. If you're not working after your transplant, you can come down to our clinic and help us. And then basal cell cancer is still sun-exposed areas most common. If you have a basal cell cancer and you're in the general population, you have about a 1 out of 2 chance you're going to get another one within 3 years. So multiply that by another factor probably if you have had your skin cancers. And then here's one of the mimickers. How many of you got a little bit more oily after you started your immunosuppressant medicines? Maybe felt little bumps around the hair follicles on your face and wish they weren't there. Those bumps around the follicles often look shiny and can mimic a basal cell cancer. Last one, melanoma. What color are you looking for? Dark. All right, so here's what we're looking for. The A, B, C, D, and E's, a new or changing lesion, or the ugly duckling. So sun-exposed area is most common, except when you're younger. Melanomas usually occur on the trunk and proximal extremities, which are areas that you get sunburn on. Like take your shirt off on the weekends or on your vacation, you get burned and you put it back on. When you're younger, that's where they happen more commonly. As we age, they usually happen in the sun-exposed areas more commonly. Where's the melanoma? All right, dark spot, that's an easy one, right? I'm going to skip over these. Other examples of melanoma, they're dark, they're irregular, different colors within the same lesion. As we age, they're more likely to be in chronically sun-exposed areas and they become more subtle. Many of us have liver spots. You heard that term before? Liver spots that are brown and look kind of like this. So the tip is this one's changing. It's getting bigger. And it's larger than many of the regular sunspots. That turned out to be a melanoma. They don't always have to be in sun-exposed areas, and you guys, especially with your immunosuppressant medicines, want to be extra cautious if you have a new growth that it doesn't fit the mold. It's not pink and rough, which you'd think it might be a, what is it going to be if it's pink and rough usually? Squamous cell cancer. It's not pink and shiny, so it's probably not going to be a basal cell. And it's not dark, so it's probably not going to be a melanoma. And it's in between my toes, so it's not in the sun-exposed area. What is it? You want to be extra cautious. A new growth, you guys can make funny growths, things that aren't typical. So this turned out to be a melanoma. And that's one that we wish we could have caught earlier. They can happen on the bottom of your feet. So new growths in different places. How many of you developed some fungus around on your feet after the transplant? You got some rough scaly areas on your toes or a couple toenails that are a little thicker and whiter than before? That scaling that you get on your feet because of the immunosuppressants can mimic and hide some different skin cancers. Where's the melanoma? Is it 1, 2, or 3? 3. All right, good. You guys are all good dermatologists. Where's the melanoma? Is it 1, 2, or 3? 2. All right, good. Now, why'd you pick those out? Because these features jumped out at you. The asymmetry, the irregular borders, the variegated colors, the bigger size, and the evolving lesion. So asymmetry, split the lesion in half, one side's different than the other. B, borders irregular or indistinct. C, colors, multiple colors within the same lesion. D, diameter, it's bigger than most of your other moles. And E, they can be small, but they change. So evolving, if you have a changing lesion, You want to get it checked out, and you want to catch them a lot faster than this one. Not all melanomas have those features. So remember the rule. If you have a new growth that's changing, you guys want to get it checked out. Now, we taught you to look for, what colors are you looking for? What's the main colors? Pink or dark, right? If it's pink and rough, you're going to get it checked out because you're worried about what? Squamous cell cancer. If it's pink and shiny, you're going to get it checked out because you're worried about what? So you're going to come to your doctor now with a lesion like this and say, hey, I got this new pink spot, looks a little shiny. I think it's a basal cell cancer. Your doctor will say, not the most typical lesion, but I can't tell you for sure what it is. This turned out to be a melanoma. But you guys now will detect it because even the melanomas that aren't typical usually will be at least pink. So a new pink spot. Now what if you look like this? You got so many moles, you need some help. You got to find, how do you find the one that changes in there? If it changes in size or color or elevation, you want to get it checked out. When you have lots of moles, it can be difficult to do that. So you might need a little help. You want to get pictures. We can give you full body photos for you so that you have a reference. If you have a new lesion after the age of 40 and it's dark, don't sit on it, get it checked out. This happened to be a melanoma that just popped up. And if you've got skin like this, we can set you up with photographs that'll help you. Now, where's the melanoma?
Top left.
Okay, so if you have so many moles that it's hard for you to keep track, you can do two things. You get a reference so that you've got something to look at and say, is that new? Is that one changed? Or when you're looking at your skin, you get out of the shower, look from far away and say, is there something jumping out at me because it's bigger, darker, and certainly that one does too. All right, so where's melanoma? Is it 1, 2, 3? All right, you guys are not going to miss a thing. You got it? And so now we know what we're looking for. And remember, the most common malignancy that you're going to get, what is it? Skin cancer. The most common malignancy of any type is skin cancer. The most common skin cancer among those is squamous cell cancer. Squamous cell cancer is usually going to be what color? How's it going to feel? All right. What's the second most common one that you could get? Basal cell cancer. What color is it going to be? What's the texture like? Shiny. And then the third most common one is melanoma. What are you looking for? Any new or changing dark spot, get it checked out. So you can control how you catch almost every single skin cancer. There are going to be some rare exceptions. But if you're vigilant now, we're going to be able to help you stay in good shape. And skin cancer shouldn't be your long-term problem. We might have to see you more visits than you want. Jim talked about us having to take all your clothes off. We're very sensitive to how vulnerable a position that is. I hope that several of our patients are here, that it's very clear how careful we are to do that discreetly. We cover you up and we examine parts of your body at once so you're not just totally exposed. So we will help you stay healthy with as much dignity as you can have. And we hope that you leave from the experience with a lot of confidence that you can find your pink and shiny spots. What are they going to be? Pink and shiny, pink and rough, and dark spots. All right. When you all need jobs, let us know. You're trained as well as our residents now. All right. Thank you.
Thank you, Jeff. I'm going to ask our panel to come up to the table to take some questions at this point. We have 2 microphones that will be working here, so you can pass them back and forth as needed. And so, what questions do you have?
Are the lung tumors, do they tend to be the same cell type, or are we seeing multiple types of cancers in the lung?
I'm sorry.
Are you seeing just one cell type in lung cancers and the immune suppressed, or are you seeing a variety of ones that behave differently, or just we get a variety of lung cancers, or is it all one sort of cell line that you see?
So you can have a variety, including metastases from other cancers. But generally speaking, if there's a recurrence, then it's usually the same type of cancer.
Someone else? Bob?
EBV. I sort of am equating it in my head to CMV, where you know whether the recipient had it beforehand or not,
Correct.
or whether the donor had it beforehand or not.
Correct.
And I know you treat prophylactically because been there, done that. And so I'm thinking of EBV in a similar. I may be wrong in doing that, but that's what I'm thinking about. And so, is there?
Right.
I know that you said
So-
you're working on new protocols.
Right, new protocols for screening. There isn't, so with CMV, there's a treatment using, again, cyclovir or one of the cyclovirs. The same is not true of EBV. There isn't a way for us to treat and cure EBV or to prophylax against EBV. And again, not all of the PTLD is EBV positive, only half of it. And so we would be, first of all, there isn't really a therapy that we could use. And secondly, even if there were a therapy that we could use, it would only be treating half of the people that we would be worried about in the first place.
Okay, so knowing whether you have anyway or you got as a result of your transplant EBV in you.
So
I won't say it's irrelevant, but
it's not irrelevant, you're right, it's not irrelevant, but we do pay very close attention to those folks who are EBV negative and get an EBV positive organ. So if you come in, for example, with a fever and you're 5 years out from transplant and can't really explain where that fever is coming from, we certainly are going to look at your EBV positivity. So whether or not you were positive or negative, whether or not your donor was positive or negative, and it'll lead us down the pathway. For example, if you were negative and the donor was positive, we would look harder to find PTLD if there was no other explanation for a fever.
thank you.
Someone else? Okay, Fred?
They say to make an appointment every year to see a dermatologist. When I do that every year, so I see a regular dermatologist. Should I make an appointment to see like the specialist because I'm 7 years out? This March. Should I see one of you guys instead of just a regular dermatologist?
Most dermatologists are going to do a fantastic job for you. So what ends up happening, and it really is the best use of our resources, is if when our clinic ends up focusing on patients who are at highest risk or have already developed multiple skin cancers or have a history of skin cancer. So if your skin's looking good and you've been at your dermatologist for these past 7 years and you keep getting a clean bill of health, then don't worry about changing. But if you're finding that you're going back and forth over and over again to get multiple lesions treated, then we can really help with your quality of life because we do a lot of same-day biopsies and treatments when you have multiple lesions. Instead of biopsy, wait till you get the result, come back at a separate visit. We still do that for many of our patients, especially if they don't have that many. But once they start to develop a lot of lesions, we're focusing on how do we make sure we catch these as efficiently as possible and maintain as good a quality of life as we can for you so you don't feel like you're in hospital at dermatologists all the time.
Thank you.
Anyone else? Yes,
I
sir.
think Dr. Shin wanted to mention one thing.
Just wanted to
Yeah.
mention one thing. We work very closely with your local dermatologist. I think what is really important also to emphasize that if you are treated for any skin cancers, it's great to inform your transplant team and sometimes even bring records so that we can scan them into your chart, because we do know from our study that Penn participated in that these skin cancers are definitely underreported, so they're underreported to UNOS. And so what we would like to avoid is just have, somebody on, who's being followed locally, and we just don't have a record of them, not doing well. And so sometimes, once you get into trouble on the outside, it's a little bit more challenging if you don't have all that history and your transplant team doesn't know about it. So I think communication is great.
Yes, sir.
Yeah, you mentioned about pre-cancers, the liver spots and stuff like liver brown spots. What are you feeling about laser treatments as far as eliminating those before they get
So for liver spots, I think it's really important that you get all of your lesions, especially the ones that are colored or pigmented, examined by a board certified trained dermatologist. And if they are truly benign, things called liver spots, lentigines, they're also called like sunspots or whatnot. Personally, we don't like to laser them off unless we know for sure that they are benign, meaning that they're not harmful. We have seen patients who have had what looked like just a very regular sunspot treated with laser or cream or freezing, and they'll go away for a time because the pigmentation, that dark color, will go away because those cells are exquisitely sensitive to freezing. But they'll come back, and sometimes what was really frozen was a melanoma, an early melanoma that comes back. So I would be very, very cautious about treating, especially on the head and neck, where sometimes it's very hard to tell what is a normal or a benign lesion, even if it's flat, has no texture, versus something that can be concerning. So I would be very cautious, especially on the sun exposed areas in the head and neck. Discourage it unless that you're absolutely sure that it's benign. And sometimes our eyes can be it can be challenging to tell just with our eyes, and we may sometimes need a biopsy them to prove that they're actually not something that needs to be surgically removed.
Who?
That one chart that you had that had the incidence of malignancy and then time out of transplant, I think for that 15 years, it was about 50%. Is there any history or data beyond 15 years, like how would that line continue?
So it's likely that it would continue to go down. The median time that someone has a heart is just about 12 and a half to 13 years. And those 20 plus year people, sit way at the end of it, and so we don't have as many people, but, just like in the general population, the older you are, the more likely you are to develop a malignancy. The same is true for transplant patients, so you would figure that it would continue to go.
Yes, sir.
Are the risks doubled for full transplant?
Sorry, for heart, lung?
Heart, liver.
Oh, heart, liver. So
I noticed also you didn't have any data for the liver transplant, because a lot of it was kidney and lung transplant. Is there more data on liver transplant? 'Cause
Yes.
liver-
yeah, so we do have some data on liver. So I try to tailor the presentation mostly to the thoracic organs. From that incident study that we did, so we kind of just separate thoracic and abdominal. So compared to the two, we actually we don't have just because it's a minority of patients that have a heart and liver.
Right.
So I think heart kidney might be even more common, but we do know. So that was just that was for that study. But we do know that the immunosuppression regimen plays a big part of it. So what I would say is it may not necessarily be the actual organ. It's really the result of the degree of immunosuppression that you have to receive in order to maintain that graft. So for you, liver versus heart, your heart is the organ that's going to need a higher degree of immunosuppression. So I would probably consider you in the thoracic organ category. But it's not very common that we have patients with multiple organs transplanted. So you are sort of in a unique population, but I would probably put you more in the thoracic organ category.
So
You have
it's,
time?
I'm
Okay,
sorry,
go ahead.
so it is true that if you have a heart liver, that we do not immunosuppress you nearly as much because the risk of rejection is much lower. So therefore, it would stand to reason that any of the cancers that one would get that would have anything to do with immunosuppression would be less because you are immunosuppressed a lot less than someone who has a heart alone or even a heart kidney.
Time for about 2 more questions before lunch. Yes, sir.
I never had acne in my face before into my heart transplant. And it comes and goes. Should I be concerned about that? Or?
So we have a lot of patients who are transplanted as adults that then come back and say, hey, I feel like I'm a teenager again because they've got acne, not just on their face, but on their chest and back. So, and that's really a direct effect of the long-term use of prednisone. So we call it something called steroid-induced acne. And it can be a bother, but a necessary kind of side effect because you have to be on the prednisone. There's ways that you can treat the acne to make it a little bit more tolerable or livable. There's really no cure, so to speak, for acne. We have lots of different regimens that we can go through with you. A lot of them are available over the counter now. Things that are very easy to use, like a body wash, even every day, a benzoyl peroxide wash, or a bar soap that contains benzoyl peroxide that you can use to kind of decrease really the severity of the acne. But yeah, it is a very common complaint, not dangerous, not a threat to your health, but definitely a nuisance that.
Well, that was my concern. Thank you.
Yes, sir.
Hi, doctors.
Go ahead.
Just 2 quick ones. This range of skin cancers, is there the pain associated with any of them for a patient?
The good news is that in their early stages, most of them don't have pain. However, remember how we talked about those warty growths that you might have gotten or have seen? The benign ones usually do not have inflammation at the base of the spot. It's usually just a warty spot without that pink base to it. And one of the signs that we use to help us distinguish when we should biopsy one of those warty growths is if it develops a little bit of redness and often some tenderness at the base of it.
Okay.
But most skin cancers don't hurt until they're more advanced.
Second,
Second.
facility out on 70 in Cherry Hill. Do either of you do any practice at that new facility?
Neither of us will be there. We're both part of that center, that Penn Dermatology Oncology Center. And
Yeah, I know.
we keep the specialized clinics here, as you know, but our dermatology team there is more than capable of helping out. And like we said, downtown we often end up focusing on people who have more lesions and need a little bit more help to keep control.
Can I ask just one quick question from you guys? So we talked about the lesions being pink, for example, and that helps you differentiate. What about people who are darker skinned? What exactly would they be looking for?
Do you want to? You can still pick up degrees of inflammation in the darker skin. So the texture changes are constant. The roughness, which you're thinking about squamous cell cancer, or the shiny, you're thinking about basal cell cancer, those are constant regardless of the skin type. But even in darker skin, the type you can pick up a little bit of the inflammation. But I was showing mostly Caucasian skin because that is where it happens most commonly. One thing we didn't say for darker skin types is the distribution of melanoma in particular is different. In darker skin types, the most common place to get melanoma is on the hands and feet, including under the nails. In lighter skin types, they're usually much more common in a sun distribution.
I want to thank everybody. There is more time for questions, so if you have another urgent question, please address it to the individual right after. I have to say, we are so fortunate because I count these people as my friends. I've been treated many times by Chris, and going back, I just celebrated my 22nd anniversary of a heart transplant about a week ago. And the reason I can do that is because our transplant team has all these supporting groups that are experienced with our transplants, okay? The average doctor doesn't know about the higher risk, let's say. And so by coming to the teams that they recommend, you get that specialized care of experience because they see so many of us. Back in 2000, I was diagnosed with prostate cancer. It was cured with radiation in Penn. 2012, they found kidney cancer. Again, usually through some ancillary testing they're doing, and they took 2/3 of one of my kidneys out. I'm cured of that. I've had skin cancers for the past number of years, and again, it's all part of the story because it's been taken care of early. And that's the message. Look for these symptoms, follow the testing programs we've just heard here, see the doctors when you have a question. Don't try and turn to your spouse, your caregiver. What do you think? No, they're not trained for that. They should say, I think we should go see the doctor. And then you'll be here, hopefully many years later, saying, I'm out 22 years. I'm out 25 years. And I got to tell you, it was fun just watching the smiles on the face because, you know, after a heart transplant, whether you're a caregiver or the patient, you really appreciate getting up and seeing a beautiful day like today and coming out here and seeing all these people celebrating life every day through the support of teams like we've heard here. So again, thank you very much. I'm going to wrap up with a couple
How about thanks to Jim for all of that?
Some quick things before we get out to lunch, okay? As I've said before, Trio Philadelphia put together a book for children. And I always bring a couple of these books in case you have grandchildren or children that need the support of this. They're free books. Just come up and ask for them. I've got about 6 of them here if you need them, okay? Secondly, my interest in post-transplant cancer, why I got involved with Rundlin as an example, is we have at the national level a post-transplant cancer project that scans out 5 years of trying to do things to help patients like ourselves who don't have the benefit of, let's say, this presentation. This presentation will be up on YouTube, hopefully in about a day or two. So you'll be able to share it with friends, point it to others, and it's part of a library of these kind of presentations. We have 82 programs now. They're not all up on YouTube. The last 15 or so are up there. But if you have, when you go to the TRIO website, trioweb.org, you can find under resources this transplant presentation library. If you see a title in the first 50 or so that's not clickable, if you let me know, you can do it through the social workers, whatever, I'll be glad to convert and load it up there. We didn't originally do that. We luckily had a snowstorm one time and a lot of people couldn't get here, and so we started putting it online. And so this will be online, as Ronald's earlier presentation was clickable also. And so we've developed, and I'm going to say I'm very proud of this, this is a website of information about post-transplant cancers. It's organized around the 4 L's. Learn about the higher risk of cancer by your organ type. Look for the symptoms of the most common types of cancers. The 4th L, live with the life cycle of cancer, right? Prevention, diagnosis, treatment, long-term recovery, and then finally links to online resources that will help you. That was deemed as being too complex for many users out on the web, and so we changed the view of that. This is the same website now with a much more friendly user interface. So you see the learn, look, live, and link over on the left. You click on one of those and you get exactly what you just saw there. So I highly recommend this. Out on the table, there's a business card, and it has the picture you just saw up there, that one, and on the other side it has that picture, and the website address is there. So please pick one of those up. It's still under development. We're still looking for some funding to finish it, but you'll get the concept, and there's a lot there. Patient testimonials, for example, is there. Part of our faculty, Chris Miller, as an example. Ronald, part of the message is out there. And so slowly I'm editing presentations like this into those topic areas. There's 24 topic areas out there. I'm getting very slow at it. So in summary, our daily challenge, I repeat this every time, we do not defeat death with transplant. We're all going to die someday, right? Rather, we gain an extension of life. And so the challenge is, the real question becomes, what are we going to do with the days, months, and hopefully years of extended life? The same question even our non-transplanted friends face in their own lives. Inspiration, I want to live until I die. Simple as that. And I got to tell you, I'm getting younger every year. I had a hip replacement just 2 months ago, and so I'm not leaning over like I was last time. I'm walking around like I wasn't last time. I feel a lot younger. We got an artificial knee. We got a hip that was amazing. I mean, literally, Ham wheeled me in a wheelchair to the surgery. After surgery, when you woke up, they said, "You want to try and stand up?" I wasn't so sure about that, given the pain I went into. I stood up. Where's that pain? It was painless. Left there with a walker 2 nights later. 3 days later, put the walker aside with the pain, went to church on Sunday and said, "Thank you, Jesus." And from that point on, no pain through the whole operation. Dr. Charles Nelson over Pennsylvania Hospital, part of Penn Orthopedics. I highly recommend, it was recommended to me, if you're suffering with something like hip pain, don't do it. Go get fixed. They do amazing work over there. Anyway, with that, I just feel so much younger. I'm 73 and I'm finding out with more meetings I go to, I'm the oldest one in the meeting. And so, I want to say thank you to our panelists. And if I may, we have a book. Chris, Dr. Shin. Thank you. Thank you. And if our social workers could come up, and I hope this is a different book than we gave you last time. Courtney, our new, come on over this way if you would, so we're in camera range. Deb Gordon. What am I Thank you for all you do. Courtney, you've joined a great team, okay? We hug her. Our people hug, don't we? Yeah. Okay? Thank you very much.
And just I wanted
yes.
to make a special thank you
Please.
to the Heart of Gold Fund for making these educational programs possible for all of us.
And what is the Heart of Gold Fund?
It's just been an instrumental program to help support many different programs. So, and I also want to make a mention, we have our next program coming up Friday, April 28th. And Sally's texting me saying that lunch is way ready. So around the bend whenever you
Wait,
have
before you get out, one last thing.
Yep.
All right, well, I'd like you to come on down. If you haven't already received one of these second chance badges, please come on down and get it.